Well, hello to everyone this afternoon. I hope there are going to be some people out there who I know and you know me. Hello to you. It's lovely to be joining you this afternoon, and hello to everyone else in the ether. It's good to be with you. We're going to talk about CLL and COVID and some treatment. I've got some slides I'd like to share with you. Please bear in mind that I'm not here to make policy. I'm not involved in any policy committees, and there are really very few definitive answers to all of this. So I hope very much that we'll be able to explore it together and discuss this major issue of our time. So it's clear this is from Worldometer. You may be familiar with some of the data that's available out there. 13.5 million people and over 500,000 people have died from coronavirus. And over the world, we can see that the level is still going up. So this is not something that is globally receding at this time. I'm going to compare some data in the US. And what's concerning is the shape of some of these graphs, and where there might be an early steep rise that showed some evidence of decline right up to the beginning of June. In the US, at least, it does appear to be increasing again. And that's also true in places like Florida, where the level is going back up again. And the signal for people dying in the US is possibly increasing as well. In the UK, the tale has been one of an increase, a rapid increase over a period of time, and then a very rather slow decline in the new cases and a decline in the number of people who are dying. So we do know that this virus is now less prevalent in the population, and it has declined in number. So there are fewer people out in the community who have this condition. We all listen to the radio, we listen to the data that comes through, read the papers. I listened with interest to a professor, I believe he was from the Office of National Statistics, talking about a large study that suggested that the prevalence at that time when they were doing it, in early June, I understand, was about 1 in 2,000. So the chances of meeting somebody in the street, possibly at that sort of level. We need to talk about risk, because risk and our perception of risk is something that varies from one person to another. We don't all have the same perception of risk at all. We have a barometer inside us that accepts or rejects risks of all kinds. So some people will be very keen to go whitewater rafting and bungee jumping both at the same time, and others who will be much more circumspect. But we all accept that in our lives, there is some risk. There's risk in the environment and risk in what we do, whether it's crossing the road, driving a car, or undergoing an operation. We accept that there was risk, but it can be controlled through the environment and through policies and procedures and the professionalism of those we interact with. Watching and waiting, like this Banksy drawing, there's a man who can't stand the multicolored rain, and the child who's playing with it. Watching and waiting can be a blessing or a curse. We often focus on the risk and benefit ratio of various treatment options that are put before us. So when I discuss this with my patients, we talk about risk and the goals of treatment. But the innate risks for any one individual, not fully appreciated. So when we think about the risks of CLL and coronavirus, then we're going to talk about that in a bit more detail. But in the context of the decline in immune function. I'm not sure that Richter's transformation is specifically relevant in most cases. And of course, we think about risk and the environmental factors, we factor that in. It's built in to the way we live our lives until something so very new and challenging comes along. So the risk can be thought of at various levels. There's our own personal risk, what the factors are about us that might be important. What is it about CLL that changes the risk? What is it about the treatments that might alter that risk? And then what other factors could be important? Age, gender, ethnicity, BMI, comorbidity. These all could be potentially important risk factors. There are organizational, structural risks. Workplaces talk about COVID security. How do we manage our homes and keep our homes as risk-free as possible? And how is this impacted on the NHS and the caregiving process? And then there are systemic risks and how this can be mitigated and managed. We've heard from Professor Pollard about vaccines. I'm going to touch on this again, so we'll talk a little bit about vaccines in any case. Clinical trials in COVID. The whole process of social distancing and how restrictions are gradually being eased and lifted as time goes by, and the value of masks. So there are systemic aspects of risk as well. So it's not all about CLL, but it's CLL in context. And I hope we'll be able to explore some of this together. Of course, CLL is difficult. People with CLL have damaged immunity, and this increases the risk of infection and increases the severity of infection and the likelihood of getting infection in the first place. About 30% of people with CLL, according to some studies at least, will die because of infection as the primary cause of death. And there is a progressive immunological problem, an incompetence of the immune system, which is complex. It's not just one thing. It's independent treatment, but it can be made worse by treatment. And of course, it will interact with comorbidities. That's our technical term for what else is going on. All the other factors that increase frailty, age, underlying lung diseases, heart disease, and other risks. So there are well-established profiles of infection. We're all familiar with seasonal flu problems, viral problems, bacterial infections that we get from time to time, and managing those and the risk that might increase with treatments and neutropenia, for example, and the risk of opportunistic infection, such as pneumocystis or other viral and fungal infections, particularly associated with therapies. I'm not going to go into detail in this study, but just to introduce that CLL is a B cell, and B cells make immunoglobulins, they make antibodies. That's what they do, that's their role in life. And the CLL cell is damaged, it doesn't produce a useful antibody, it's not contributing to our immune systems in any way. And there are other cells called T cells, and these are the conductor of the immune system. We'll look at those in more detail as well. Neutrophils, frontline infection-fighting cells, usually containing granules that sidle up to bacteria, can discharge their granules onto the bacteria and kill them off. And then there are the whole body factors related to general health. And then where we are in the world, what the economics are, and what the prevalent illnesses and diseases are in the society. So what about incidence and predictors of infection in CLL? This is a study from 2018, published in Haematology, the European journal, essentially of haematology, mouthpiece of the European Haematology Association. This is a big study, nearly 3,000 people with CLL of all levels. And you can see that infection increases as time goes by. So the message is the risk of infection increases, and it's not a totally insignificant level. It's about a third here. So 30%, 31% severe infection within the first 5 years of diagnosis. This is a bit of a busy slide, but suffice it to say that there are factors that also increase the risk of infection that relate to the CLL as well. So unmutated CLL, slightly increased risk. Age, absolutely increased risk there in the over 80 group. Men, well, we're subject to more things. We get more infections. Advanced stage CLL is associated with an increased risk. And then levels of antibodies, IgG, predominantly, probably the most important one, but IgM and IgA as well, all have an influence on the risk of infection. The lower the antibodies, the higher the risk. BSH, British Society for Haematology, put out some guidelines on managing CLL, but this included some aspects of how can we manage infection and infection risk. So this was published only 2 years ago now, and we talked about seasonal flu vaccines, pneumonia vaccines, checking the blood test to see if there's a dynamic response to the vaccines, and access to immunoglobulin for those people with CLL, a low antibody level, and infections despite prophylactic antibiotics. You also need to know what those antibody levels are after the vaccine. So please be clear with your clinical team. Have you had the pneumonia vaccines and what was your response to it? And then in the context usually of therapy, prophylactic cotrimoxazole and acyclovir particularly. So this is sort of well-established scenarios. Doesn't actually tell us about COVID and CLL. So talking about antibodies and vaccines, we heard from Professor Pollard the very encouraging perspective that the AstraZeneca vaccine produced in Oxford, working with the company to produce this vaccine, may be something that has little risk for people who are immunocompromised, and that's extremely encouraging to hear. And I do hope that's going to be borne out in clinical trials. And it may partly address the issue of toxicity. We don't know whether it's going to address the issue of efficacy. So will the vaccine work in people with CLL? We don't know that yet. And I think this will demand some clinical trial studies to work out. But encouraging perhaps that for CLL, where we would not normally consider using live vaccines, that there's the possibility that it could be available with this coronavirus vaccine. There are other kinds of vaccines available as well. So inactivated vaccines. So the whooping cough and polio are inactivated viruses, and the polio virus, even though it's inactivated, can be excreted for some time for this particular vaccine. Toxoid vaccines, so some bacteria, for example, will produce toxins, and you can create that protein, recreate the bit that will stimulate the immune system and use that as the basis of the vaccine. So tetanus and diphtheria, for example. And then subunit vaccines. These are safe and they're well tolerated. And patients with CLL will often get the pneumococcal vaccine, polysaccharide vaccine, and the conjugate vaccine, Prevnar 13, PCV 13. So our standard practice is to use both these vaccines in CLL, PCV 13, as well as the Pneumovax. So please do check your vaccine history and see that you have had these. Cellular immunity is another part of our immune system, and the T cell. This is a picture of Sir Simon Rattle, and the orchestra will make lots of noise, and it'll have a fair go at producing the symphony, but to make it shine, to polish it, to bring out the subtleties of notes and the coordination of the music, it requires the skill of the conductor. And one of the roles of the T cell is to conduct the immune system, to compare notes with antigen-presenting cells, cells that pick up bits of proteins that the immune system can then recognize. The T cell will say, yes, I know what this is, and will identify the B cell and instruct it to go away and make the antibody. So we can't manage very well without T cells. We can do most things, but there are infections that will just sneak under the radar. This is a complex interaction between the cell, the T cell, and its subforms. I'm going to go into that in detail. And we also know that T cell numbers will reduce often dramatically with therapy. This is a population-based study using bendamustine and rituximab, and it shows on the graph on the left-hand side, here's our magic number, 0.2, 200 in our parlance, and it takes just over 2 years for the T cells, the CD4 cells, to recover after bendamustine. And for some people, it recovers more quickly, and for some people, it recovers more slowly and can take much longer, maybe even up to 3.5 years in some cases. So a reduction in the T cell numbers with treatment, and that's an important consideration. One of the consequences is pneumocystis pneumonia, and here's the bat of the bat wing, typical appearance on a CT scan, and the organisms can be seen here and here in an alveolus with some inflammatory cells as well. And the typical symptoms of pneumocystis would be temperatures, fatigue, getting short of breath, chest pains, dry cough, low oxygen levels. In fact, similar clinical presentation in some ways to COVID-19, a very serious condition if it establishes in the immune suppressed. Zoster virus, shingles, in essence, chickenpox. Many people will be familiar with this very uncomfortable, potentially extremely painful and debilitating post-hepatic neuralgia can arise. So if we can prevent it with prophylactic acyclovir, for example, in the context of some treatments, or treat it as soon as possible, that's quite important in CLL. There are vaccines against shingles, against this virus. However, the varicella zoster vaccine, the live vaccine, is not recommended for patients with CLL. That's the only one that's available to us in the UK at the moment. There is another called Shingrix, that's the recombinant vaccine, and that may be available in due course, in time. I don't know when it might be. It has been licensed within Europe, and I think we need to keep looking out for that. But until such time as Shingrix is available, the live vaccine is not recommended in CLL. And if your GP or the GP's nurse says, oh, do have the shingles vaccine, please be very circumspect about that. It may be the live vaccine, and it would be important to query it and question it and confirm with your clinical team whether this is something that might be suitable for you. But in general, the advice would be CLL, please don't have the live shingles vaccine. I'm going to move on to COVID-19. I'm grateful to my colleagues in the respiratory unit for supplying some x-rays. And the x-ray appearances are often on both sides, and you can see these fluffy changes in the lung fields as the disease takes hold and causes inflammatory change in the lungs, which then translates into a drop in oxygen and the need to have the CPAP mask or ventilation. And this is one of the conditions that the dexamethasone was beginning to show a positive signal. If you remember that the dexamethasone story only a few weeks ago, that it shows benefit for those people who require oxygen for coronavirus. It's not something that we would prescribe for asymptomatic or for early phase or mild cases. In the NHS, the processes and protocols for managing COVID-19 have become increasingly sophisticated as the environment has become more familiar to those who are managing. And please don't forget but I'm not an emergency physician. I don't work on the ITU. I'm not a virologist or a respiratory clinician. So I'm less familiar with the clinical aspects of managing the cases, but I've reviewed the stories of a number of people. Symptoms in the early stage will include the temperature, the fever, the headache, possibly diarrhea, and loss of taste, loss of smell. That's recently been written in as one of the key symptoms. Usually into the second week, the later part of the stage 2 pulmonary part, increasing shortness of breath, cough, temperature, breathing more rapidly, that's respiratory rate, and becoming hypoxic, so 93%. Normally we'd have an oxygen level in our bloods of above 96, 97%, often 98, 99, or even 100% just on air. And if it goes lower, then the oxygen will come out of the red blood cell. It can't travel around the body and cannot supply oxygen to the parts of to the organs of our body that need it, our brains, our hearts, and kidneys, liver. And then in the later stages, 2 weeks into the disease, often more increasing shortness of breath and worsening of hypoxia. There may be things that we can pick up in the blood. So the blood tests can often be helpful. So low lymphocytes, for example. And X-ray changes will increase as time goes by. We've become more familiar with some of the risk factors that may be clear. And we're going to talk a little bit more about those risk factors anyway. There's some modeling around when the virus begins to appear and when the symptoms are. We think at the moment that possibly COVID is a little bit more like seasonal flu in the timing, that there's a very short interval before people become very highly infective. It's not something that's necessarily delayed as might have been seen in the early SARS story. And this is some data showing that hospital admissions with COVID testing is much more likely in the over 50s, 60s, 70s, and then a big spike in the over 70s. So age is a very important part of who gets admitted to hospital and tested, with this male preponderance here. It's more subtle on this graph, slightly less subtle and a bit more worrying, with a clearer gender signal for ITU admissions. So you're more likely to be admitted to ITU the older we are. This is here in Leicester, so this is some local data that I'm very grateful to my colleagues for sharing. Just to show that the number of tests and proportion of tests as people are older will increase. So the number of people with testing for positive in the hospital is, as a percentage, goes up with age. It goes up slightly less in those who are clearly negative. I mean, there's a lot of interest in the role of BTK inhibitors and infection. And when I sit down with my patients and talk about treatment with ibrutinib, largely, this is, one can be perceived as the hematologist who is lobbing in a therapy which is potentially loaded with side effects and risks. But we also know that the risk profile of drugs like ibrutinib is quite different from combination chemotherapies, bendamustine, FCR, for example. So it's a bit of a two-edged sword. There is a signal. So did BTK inhibitors increase the risk of infection? Well, they might do. There are signals. So there's some older data here going back just 3 years. This is case reports of pneumocystis in previously untreated patients on single-agent ibrutinib. So people who you think were at a low risk of opportunistic infection can still get pneumocystis. Other studies too, this is a real-world study from the US on 378 patients with CLL and a few others with a similar disorder, mantle cell lymphoma, showing that there were infections in a significant number of people, including invasive fungal infection, pneumocystis, and some people died of infection. And these were infections that were arising on ibrutinib. In EHA this year, that's the European Haematology Association, there were a number of papers that were presented on acalabrutinib, one of the newer BTK inhibitors that people will be very interested to hear about. So this is a study across Europe and comparing the use of idelalisib and rituximab against acalabrutinib and bendamustine rituximab in relapsed refractory CLL. That's people who've had treatment before. And the study was essentially that 310 patients, they'd had CLL for a long time, they'd had previous treatment and needed therapy again. And in this study, they were assigned either to acalabrutinib, idelalisib, or bendamustine, okay? And they had good response rates across the board. There was no obvious survival difference, but there are differences in toxicity. So let's just have a quick look at acalabrutinib, 154 patients, and how many infections in there. So grade 3 infections, infections that really required intervention and may have involved a hospital stay. There were 30 patients, 20% had severe infection. Let's have a quick look at some of these other things. So atrial fibrillation and hemorrhage problems, modest, but I've got some comparative data as well, which is interesting. Okay, so that's previously treated patients who may have had poorer immune systems. What about those people who'd never had treatment before? Treatment naive CLL. So this is a study from the US, which was reported by John Bird. And untreated CLL that requires treatment, and they were assigned to acalabrutinib at different doses. 99 patients in this study. So what did they find in this? They found that the risk of infection in here, particularly upper respiratory tract infection, the severe ones, not a high number, but there is a signal there. So a number of people, 38%, 38 out of the 99 patients had upper respiratory tract infections, of which only a small number, just one in this case, required more serious intervention. Good news is that some of those side effects get better over time. So each of these bar graphs is conducted measuring some of these side effects at different intervals, and you can see the time intervals here on the right-hand side. So going over the years, that diarrhea reduces, headache reduces, the risk of upper respiratory tract infection, it sort of grumbles along a little bit. It's a bit variable. It's probably not significant. Arthralgia comes down, bruising comes down, weight changes, nausea, generally side effects improve as time goes by. The response to acalabrutinib, excellent responses, 90% overall response rates with a number of complete responses. Best change in tumor size. Now this is called a waterfall plot. For obvious reasons, it just suggests that there's a cascade of water, and the lower it reaches, the higher the percentage of change. So down here in the bottom of the screen, 100%. So if all of those bars went down to 100%, it would mean that everyone had a disappearance of the lymph node size. So you can see that the lymph node size is reducing right down to very low levels for most people. So there's only one in there that had stable, which is less than 50% reduction. So there was a pooled study. So this is taken from a whole bunch of different clinical trials looking at acalabrutinib. So just acalabrutinib, and this is one slide to have a look at that. But they picked over 1,000 patients on acalabrutinib, and the number of infections between 15 and 20% risk of serious infection for single agent acalabrutinib. Mostly this is going to be second line therapy, second or third line. So the previously treated patients for the vast majority in this study. What about comparing acalabrutinib and ibrutinib? Are they any different? Some really interesting data coming out now. So we know that ibrutinib is very well tolerated, but there are risks, as there are with everything. But how does acalabrutinib stack up? So this is taken from a few different clinical trials, in fact. And the clinical trials were not designed to be measured this way. So it's the statisticians dovetailing them together and comparing notes. They may be comparing apples and pears slightly, but they're trying to take similar cases in each and matching them together. So they look at matched samples, matched patients. They try and work out in the acalabrutinib or ibrutinib arms of these two different studies, several different studies, what did they get? So infections, acalabrutinib as a percentage, 12%. The other one was 17.5%, if you remember. So in different studies, you're going to get different numbers, but there's a signal. They said this was statistically slightly lower. So the p-value, not the same as an r-value, it's a p-value, it's a statistical value at 24%. So the risk of infection may be slightly lower with acalabrutinib. This isn't the way to test that, but it's an interesting observation. As far as COVID is concerned, the whole business of extremely vulnerable groups came up quite early on. And you all should have received a letter from the government and then subsequently from your GP at the same time or before, and then possibly even from your hospital services to identify as extremely vulnerable, with the opportunity to register them on the NHS websites. And we know this applies to pretty much all blood cancers across the board, CLL included, and that hasn't changed. People receiving chemotherapies, radiotherapy, or targeted therapies that reduce immunity. People with severe lung diseases, severe COPD, for example. People have had organ bone marrow transplant. Those who are on immunosuppressive therapies, azathioprines, etc. Immune deficiencies. So there are some people who have immune deficiencies that they acquire later in life or through childhood, or maybe they're even born with it. So immune deficiencies outside CLL, of which there are a number, and those people will be extremely vulnerable. Sickle cell disease could cause vulnerability, extreme vulnerability, and pregnancy with heart disease was identified as being vulnerable as well. But outside CLL, of course, there are other risks as well. I mean, the key one is probably age, body mass index, obesity, which is a BMI more than 30. But in one study, one US study recently, they suggested that a BMI of 35 meant that you were twice as likely to be admitted to ICU. And that was relevant to the under 60s group. We saw some data looking at male gender and the risk of being admitted to ITU, being skewed from females towards males, being at a higher risk. The BAME group, and this is a subject of intense discussion and concern, and I'm sure research also. Heart failure, heart disease, and high blood pressure will confer an increased risk. COPD, cigarette smoking, asthma, and a whole host of other problems, diabetes in particular, will increase risk. So it's not just CLL. And some people will have multiple risk factors. There are organizational factors as well. So what can we do at work and in our homes that change and modify the risk? Nurses have always been super nurses. Nothing has changed there. Within the NHS, the response to coronavirus has been dramatic, swift, and I'm immensely proud of my colleagues who have shown such focus and dedication to developing protocols and managing the way that the NHS is working in our wards and on all the wards and ITU, all the investigational areas, all the laboratories, X-ray, the scans. They already work very, very hard. So we've moved to video and telephone, mostly telephone consultations, and I'm sure that you've had telephone consultations. We have divisions in the teams. We have clean areas, so geographically, some wards are coronavirus wards and the majority will not be. And we've aimed to provide normal services as far as possible for those who present to us and need the care within the clinical services. That it's very important. And one really important message is that if you are unwell, if you think you need the hospital care or intervention because of your CLL, or if you're watching this with some other low-grade or other hematological cancer, if you're worried about it, please tell your clinical team and do not be frightened of coming to our hospital services, because we are managing that risk as best we can to make it as safe as possible for you so that you can receive the care that you need. But it has meant that there are treatment decisions that need to be made. I mean, if somebody has clear indication for treating CLL, we need to talk about that and work out what might be the right thing to do in terms of timing. We can sometimes defer treatment in CLL, but there comes a time when treatment is clearly absolutely necessary, and to continue for longer would not be safe. We've modified our approach to things, so reducing the number of, reducing the footfall, reducing the number of people coming through the day ward area, and that means less pentamidine nebulizer for those who might need it, substituting dapsone for people who could tolerate it, thinking about how can we make intravenous immunoglobulin as safe as possible, to defer, interrupt, and to change to subcutaneous injections where possible as well. So lots of modifications in the way we're working, lots of protocols being produced and ways of trying to manage care within the wards. So this is the SPACES acronym. So a way of trying to improve and reduce risk in clinical environments, trying to multitask. So if one of the nurses or medics goes into a side room to check on a patient, then taking in food trays, removing old food trays, for example, would be such a simple thing to reduce the footfall in the side room, for example. Testing in Leicester, there was a big spike early on, and we've seen that the amount of testing has gone up, but the percentage of those with positive tests has come right down. So the percentage of people who are testing positive is reduced, and that's true even now at this time. So just a pro forma for people being admitted. So in terms of what's happening in Leicester, it's really quite interesting. We have, in general, not seen a significant change in the number of people being admitted with coronavirus. This may yet change. It's possible this is a generational thing in terms of the age of those who are positive. So for younger age group, they may be more likely to be asymptomatic or only mild in their presentation with coronavirus, and therefore less likely to need to come into hospital. So I very much hope that that will not be translated into an increase in more elderly people getting the virus and coming into hospital. But we don't know that at the moment. At the moment, that doesn't appear to have happened here in Leicester. So there are other organizational factors. What is the COVID secure workplace? The health and safety executive has been working extremely hard, clearly up and down the country. And I've heard these people talking on the radio and explaining how they're doing. They've been active in Leicester, looking at workplaces here in Leicester, and I'm sure they have been where you live as well. So the recommendations, when you look at their website, I think they're approaching this systematically, and of course trying to apply the 2-meter rule, looking at the way that floor tapes and paint can be applied to improve flow, limit the amount of movement of people in lifts and corridors, for example. Putting up big plastic screens like the ones you might have seen in your hospital department if you've been into the outpatients. We have big perspex screens around all the desks and nursing areas now. Staggered breaks and shift patterns, bubbles at work, for example, in schools, protocols around hygiene, cleaning, ventilation, and even orientation, sitting next to each other rather than face to face. The health and safety executive reminds organizations, workplaces, and those responsible that it is a legal duty to protect workers from harm. But the language is modified when it comes to the guidance around shielding workers. They should talk to shielding workers and take every possible step. And I think that this is something that that individuals will need to be comfortable with the steps being taken at work to ensure that it is safe for you to be there. Shielding, of course, I understand at the moment, is going to end or pause from the 1st of August going forward, but the coronavirus doesn't know that. Coronavirus isn't aware that shielding is going to come to an end. It's entirely indifferent to any policy decisions that may be taken around it. So we don't know what the support will look like then. I don't know if supermarkets, for example, will need to change their priorities on commercial grounds. Social distancing and mask wearing in shops will become mandatory as of next week. Social distancing remains sensible, does it not? How do we manage family and friends? How do we begin to get back to the levels of human warmth and interaction that are so important for us? It appears that the virus is less comfortable outdoors than indoors, and that may be related to ultraviolet light. It may be related to the movement of air and circulation and ventilation just naturally. I often hear stories of, I think I had this, I think I had it in January, I think I had it in February. We don't know that. Testing simply may not be available. And there are reasons to think that testing for the antibody, the response test, may not be long lasting. So we may never find this out. So please be cautious. If you think you've had it, that is no cause for any complacency. It does not confer immunity in any way. And please do not assume that that would be the case. Just a cartoon, which may be helpful. So large particles, bigger than 10 microns, so still very small, but they could be blocked. So I think if you have a mask on, then it's likely to give some protection against the transference of larger fluid particles from somebody's cough or sneeze that might otherwise have landed on your nose and mouth. So it does give some physical barrier, and of course it does help protect against the cough or sneeze that we might have behind the mask. So it catches that and collects that and protects other people as well. So it seems to be a sensible precaution. Again, it's difficult to gather objective evidence around this, but there is a body of opinion around the use of masks which suggests that it is a very sensible precaution to wear a mask. We get used to it. Okay? We get used to it. And I know they're uncomfortable for some people, but please, please do persevere with these. And it doesn't replace social distancing. If you have a mask on, it doesn't mean that you can get up front, up close and personal. Systemic factors. Social distancing, what about keeping generations apart? And how do we meet with all our families across the generations? Maintaining public discipline. We've all seen these photographs in the papers a few weeks back in the very hot weather. We sympathize with people who want to get the fresh air and go back to normality. But we all have a reaction to that as well. And we worry about public discipline and maintaining that going forward. What's going to happen later on in the year? It could be that with the colder weather, the flu season will be upon us. Is it that the virus is going to be more readily spread in the colder environment? Will there be a second wave? And how will that restriction roadmap and how will things be lifted, and where will the guidance be? Herd immunity, we've heard a lot about, is somewhat discredited as a concept in many ways. Left to ourselves, this is probably not easy to acquire, and is not a desirable outcome to be developed without the help of vaccines. So vaccines and breaking the chain, I wondered if this is a form of not social distancing, but biohazard distancing. If you have a number of people who are immune, then the virus might come across one of those and cannot be spread any further because that person cannot pass on the virus. And of course, testing and contact tracing is such an important part of that. A quick word on the antibodies. King's College published, at least it gave notification to the press of data suggesting that the antibody responses, that's our immune system response, is not, doesn't last forever. This is not something we can rely upon to give us long-term immunity. So they've suggested that it peaks about 3 weeks after infection and then begins to decline after as little as 2 or 3 months. So that's one of the reasons why, even if there is long-term extensive testing with the antibody test in the community, and for those people who may feel that they had the virus and recovered from it very early in the year, the test may not be helpful. So you can't tell from that, and it's difficult to know then how long our immunity will really live for. How that speaks to the value of vaccines, I simply cannot say. There's a lot of research going into this coronavirus, and a number of these studies performed at centres up and down the country. Just run through a few of these. The recovery trial has recruited 12,000 patients since the 23rd of March, just at the beginning of the lockdown period, at 176 sites in the UK. In Leicester, interestingly, we've recruited the large amount by a considerable margin, with over 550 patients recruited into the recovery study. And various different drugs came up and were knocked down again. So hydroxychloroquine made a guest appearance earlier on, but was eliminated. Other antiviral drugs were eliminated at the end of June for being ineffective. The news came out that dexamethasone, a steroid, was shown to reduce mortality by about 1/3 in those people who needed ventilating, and by about 20% for those who need oxygen. But there's no benefit in other people, so you don't reach for the steroid the minute that the test becomes positive or if you have a cough. This is a hospital intervention specifically for people with oxygen requirements. and the trials are ongoing. So just a quick pro forma just to show the structure of the study and moving forward. This is an interesting one. This is reinfection, so immunity and reinfection evaluation, particularly in healthcare staff. So taking the serology test, the antibody test, and nasal swabs, and then doing them on a regular basis to see whether the virus comes back and whether healthcare workers get recurrent infection. And the PHOSP study to establish a national platform to integrate the research and clinical service, improving long-term outcomes. So essentially looking at long-term outcomes for people who have had coronavirus. There are lessons. I mean, this is an NHS perspective in many ways, protecting the staff and keeping the staff safe within the NHS is absolutely paramount to ensure that normal healthcare can continue. This is the risk of morbidity, mortality increasing because of failure of normal NHS services doesn't bear thinking about. This is an extremely active, highly infective virus. The overall mortality for severe COVID-19 is probably around a third. I mean, overall, when you look at the numbers for people who test positive but are at home, that it's less than 30%. But for those who are admitted into hospital and have severe pulmonary forms, then it's very high. And I've seen data that suggests that the ITU admissions, the risk of dying in ITU, is somewhere in the order of around 50%. Trying to work out what's going to happen to you if you come into hospital with coronavirus, nobody knows that. There isn't an easy way to say, look, this is going to happen or that's going to happen, or to identify those who might be at higher risk of going to ITU. So the clinical experience from my colleagues in the respiratory unit is that they feel that this is highly complex. They can't easily predict what's going to happen. It's a difficult time. We feel that life is on hold, and for many people, dreams may already have been shattered. But we need to look forward, and we need to hold on to the optimism and hope that things will improve and change, and to hold on tight to all that is humanly precious for us. And on that note, I'm going to end. I look forward to your questions. Again, I'm going to say that I'm not here to make or to question policies, but to explore this together with you. So I'm going to hand back to Brian, and I look forward to answering questions as best I can. Thank you very much. Thank you.